GIT anomalies, TOG 2023. Starting with an introduction, the prevalence of congenital anomalies is reported as 6% worldwide, but only 2.5% in Europe. About 10% of these anomalies are gastrointestinal. The commonest of gastrointestinal anomalies are anterior abdominal wall defects, which include omphalocele and gastroschisis. And 90% of these anomalies are diagnosed during early scan, between 11 and 13 plus 6. Other GIT anomalies include atresia, such as anorectal atresia, esophageal atresia, as the most common form is duodenal atresia. The fetal anomaly screening program recommends anomaly scan between 18 and 21 weeks. In general, the antenatal detection rate for GIT anomalies is 96% for anterior abdominal wall defects and 36% for other GIT anomalies. Now let's make some details about anterior wall defect. The two important examples are omphalocele and the gastroschisis. Omphalocele is central, ventral, it is through the anterior abdominal wall, the umbilical cord, here as you see, on top of the mass. It has a smooth surface, it is covered by a membrane, and it contains intestine and liver. Liver especially is present in 50% of cases. On the other side, gastroschisis, as you see, it is para-umbilical. Umbilical cord is normal. The surface is irregular, no membrane, and it contains intestine. Other organs is rare. When looking to the ultrasound feature, you can find these criteria of omphalocele, where you can see a central, ventral mass, which is regular, covered by a membrane, and it contains intestine and umbilical cord on top. On the other side, here you can see the mass. It's para-umbilical, where the umbilical cord is normally inserted. It is irregular, with no membrane. Now let's discuss some more information about omphalocele. Regarding embryology, physiological herniation of the fetal gut occurs from 6 to 10 weeks gestation. And the failure of bowel lobes to return to the abdominal cavity after this process is considered the embryological basis of omphalocele. Prevalence is 1 in 10,000 live births. Size is variable, and it is considered giant if the size more than 5 cm or more than 50% of the liver is included. Risk factors include non-Hispanic Black, age 35 to 40 years, twins, and the male fetus. One suspected complication is pulmonary hypoplasia, especially with giant omphalocele. Omphalocele is often associated with other congenital fetal malformation, such as cardiac defects and genitourinary manifestation. In addition, 30% of cases are associated with genetic problems, such as chromosomal aneuploidy and Beckwith-Wiedemann syndrome. If karyotyping is normal, this is more common with isolated omphalocele. The diagnosis of omphalocele requires ultrasound criteria. In addition, there is markedly increased maternal serum alpha-fetoprotein. Regarding prognosis, mortality rate for live birth is 10% in cases of isolated omphalocele, and it rises more than 40% if omphalocele is associated with other anomalies. And the prognostic factors include size of omphalocele and the timing of diagnosis, with higher morbidity if omphalocele is diagnosed antenatal. In addition, postnatal examination is important, as associated anomalies are diagnosed in about 1/3 of cases. The other anterior wall defect is gastroschisis. Embryologically, it may result from disruption of the lateral body wall folds in the 4th week of human development. Diagnosis requires ultrasound features. In addition, there is a rise in maternal serum alpha-fetoprotein. When complications occurs, it is called complex gastroschisis. Complications include volvulus and ischemia or necrosis. Gastroschisis may be associated with other congenital anomalies in 14% of cases, and CNS anomalies are the most common. However, genetic problems are rare with gastroschisis. Regarding prognosis, the risk of stillbirth is increased with gastroschisis, and it is 5% at 35 weeks. However, neonatal survival is more than 90%. The other congenital anomaly is small intestine atresia and stenosis. Atresia is defined as absence of a body segment, while stenosis is a partial obstruction. Duodenal atresia is the most common form of atresia. It occurs in about 1.8 per 10,000 total births, and it is associated with other congenital anomalies in 70%, and about 1% of cases are associated with aneuploidy, usually Down syndrome. Regarding diagnosis, it is diagnosed by ultrasound by the presence of double bubble. One bubble for the stomach and the other bubble for the dilated proximal duodenum. And about 60% of cases are diagnosed antenatal. Here is the double bubble, where one bubble represents the stomach and the other bubble represents the dilated proximal duodenum. While jejunal atresia or ileal atresia are seen as dilated lobes of intestine. And the differential diagnosis of dilated lobes includes meconium ileus, volvulus, or Hirschsprung disease. In this image, we can see dilated lobes of intestine. In addition, polyhydramnios is common with GIT anomalies. Regarding prognosis, mortality rate with uncomplicated intestinal atresia less than 10%. Regarding antenatal management, perform a full ultrasound assessment for anatomy, biometry, and request fetal echocardiography if there is increased risk of cardiac anomalies, such as with omphalocele or duodenal atresia. Perform serial ultrasound to detect fetal growth restriction and also to detect polyhydramnios. Offer amnioreduction if there is significant polyhydramnios. Offer invasive testing if there is increased risk of chromosomal or genetic abnormalities, such as with omphalocele or duodenal atresia. A sample can be obtained by chorionic villus sampling or amniocentesis. Regarding delivery, it should be performed at a tertiary center. Vaginal delivery is appropriate, and the cesarean section is reserved for obstetric indications, and also if there is a giant omphalocele with liver herniation. Regarding timing, in uncomplicated gastroschisis, from 37 to 38 weeks, and in cases of uncomplicated intestinal atresia, delivery from 38 weeks. The option of termination of pregnancy can be offered under Ground E if the condition represents a serious handicap, for example due to associated congenital anomalies or genetic problems. And the feticide is required if termination is offered beyond 21 plus 6 weeks. During postnatal management, in general, a neonatologist should be present during delivery to assess respiratory compromise, assess for associated anomalies, and request echocardiography if there is a high risk of congenital heart disease, such as with associated omphalocele or duodenal atresia. An esogastric tube should be placed to decompress the stomach in case of anterior abdominal wall defects. Specific recommendation regarding omphalocele. Check blood glucose due to the association of hypoglycemia with Beckwith-Wiedemann syndrome. Regarding repair, a small defect is amenable to primary repair within the first few days of life, while the repair of giant defect is controversial. Some centers advocate an initial conservative approach, followed by a delayed repair around the age of 1 year, while others advocate early repair with the use of patches to bridge the defects. Specific recommendation for gastrosis cases includes initial resuscitation. The lower half of the infant should be placed in a gastrosis bag or bowl wrapped in cling film. Start a broad-spectrum antibiotic. Fluid resuscitation is important because of the increased risk of fluid disturbance. Following initial resuscitation, surgical repair is performed with either primary operative facial closure or a staged closure using preformed site. After surgical repair, parenteral nutrition is necessary because early enteral feeding is challenging. And finally, the special considerations for intestinal obstruction is to perform abdominal X-ray at least 2 hours after birth to allow passage of air through the bowel. If X-ray demonstrate double bubble or dilated bowel lobes, then the neonate should undergo operative exploration and management. It may be either open or laparoscopic approach, and it involves duodenostomy, where the duodenum is anastomosed to bypass the obstructed segment.